Good evening, everybody. My name is Agina Francis Makwabe. I'm the consultant physician and nephrologist working in Tanzania with Africa Healthcare Network as Chief Medical Director of AHN in Tanzania. So I'd like to welcome you all to today's AHN Nephrology Education Webinar, which is series number 58 today. So the topic today is the use of novel oral anticoagulants in dialysis patients. And it's a great honor and pleasure to welcome our today's speaker, who is very well known to most of us here, a colleague, Dr. Mubarakali Janmohamed, is a consultant nephrologist and physician from the Royal Wolverhampton NHS Trust, United Kingdom. He's one of the founding member of Nephrology Society of Tanzania, and is still a very active member, by the way. He did his Doctor of Medicine at Muhimbili University in Tanzania, and also his Masters of Medicine in Internal Medicine at Bugando University in Tanzania, and graduated in 2012. Thereafter, he migrated to United Kingdom for his MRCP. MRCP is membership, Royal College of Physicians in Nephrology. And then, yes, he also had established the Biohealth Dialysis Center in Mwanza. He was the founder and established it. And was one of the first dialysis center in that region of Tanzania. So it's a great honor and pleasure to welcome you, Dr. Mubarakali, and you are welcome to continue the presentation.
Thank you very much, Makwabe. It's an honor and a privilege to be giving a presentation on this platform. I have been an active audience on this fireside chat, and it's been a great learning experience, especially when we hear from colleagues from around the world sharing their knowledge and their experience in the field of renal medicine. So Lloyd approached me a few weeks ago or a month ago, asking about if I'm available to give a talk, a talk based on something that is relevant to East Africa or Tanzania on the practice of medicine in the developing world. And I thought about this topic. This was a topic that I presented within my own department due to the challenges we face when it comes to prescribing and monitoring the use of anticoagulants in patients who are on dialysis. All of us are aware of the fact that we have seen increasing numbers of patients who are on renal replacement therapy who develop non-valvular atrial fibrillation or other venous thromboembolic phenomena and are on long-term use of oral anticoagulants. And monitoring the use of these agents is quite challenging, especially when you have to do tests like INR and other coagulation screens on a fairly regular basis. When it comes to East Africa or to Sub-Saharan Africa in general, then there is a cost implication when these tests are ordered. So I think this is a topic that I hope everybody would find useful. And my main aim actually is to get your experience on the use of novel oral anticoagulant agents or NOACs in dialysis patients. And I would love to hear everybody speak up and tell us what their experience is like. So without wasting much of your time, I would share my screen. Just let me know if you can see my screen, please. Can everybody see this?
Yes, yes, we can see clearly.
Excellent. Okay. So yeah, just to introduce you to the topic. We have dialysis patients who use different sort of anticoagulants. But the main anticoagulants that are used amongst the dialysis population is either vitamin K antagonist or warfarin or heparin. And in the US, 40% of patients who end-stage renal disease and 1 in 8 dialysis patients in Europe have non-valvular AF. Warfarin so far has been the oral anticoagulant that has been licensed to use for long-term anticoagulation therapy amongst the dialysis population in my part of the world, in the UK. This drug was first used as a rodenticide in 1948, and it became was licensed for first use amongst humans for the management of thrombosis in the US in 1954. Just prior to that, a few years prior to that, the farmers found out that their cattle started dying of hemorrhage, and they were exsanguinating, which was either due to trauma or spontaneously. And they then realized that they were feasting on certain plants that caused these problems. And when this was investigated, and the active chemical ingredient within the plant was isolated, warfarin or coumarin, which was commonly known as at that time, was discovered. Warfarin is largely cleared from our body through the liver. It is 99% bound to plasma proteins, and therefore it is a drug that is not dialysable. So it accumulates in the human body. Now in the UK, and I'm sure in many parts of the world, if you're a doctor practicing renal medicine, the worst thing is when you get a call on a weekend evening or even on a weekday evening asking you to action an INR for a patient who is on dialysis. And this is on and on, especially with the larger number of patients who are now developing non-valvular AF or any thromboembolic phenomena and have been put on anticoagulation. The challenges associated with use of vitamin K antagonists are many. The main ones are poor INR control. And we have patients, especially those who have a definitive vascular access, who are dialyzing through a fistula or a graft, and have poor INR control, and there's problem with bleeding. However, the RELY trial showed that patients who have poor INR control also have greater decline in their eGFR, particularly when they're using, particularly when you compare that to using other anticoagulation agents. And this is mainly because of the suspicion that these patients, because of their poor INR, have recurrent subclinical bleeds within the renal tubules, resulting into recurrent or repeated bouts of ATN. These agents also prevent the activation of inhibitors of vascular calcification, the mGLA protein or the matrix GLA protein. And this was discovered experimentally, and therefore it is postulated that this is one of the commonest causes or risk factors that leads to calcification in clinical practice, and therefore it is strongly associated with calciphylaxis. And obviously this is backed with lots of circumstantial evidence. Now, the use of anticoagulants in the dialysis population comes with a controversy. It's not straightforward. What is controversial about it? If you look at the KDIGO consensus protocol, this opposes the use of vitamin K antagonists altogether for primary prevention of stroke in AF patients. In essence, the available evidence tells us that there is no evidence in the primary prevention of using vitamin K antagonists in the primary prevention of stroke in patients with AF who are on dialysis. There is no evidence. When you look at the national guidelines in Germany, their vitamin K antagonist, fenprocoupon, is not licensed in manifest renal failure as per their guidelines. However, this guideline is largely ignored in clinical practice. When you look at the American Heart Association and the American College of Cardiology, their consensus guidelines show that use of vitamin K antagonists within the dialysis population who have AF is actually useful. Coming to the European Society of Cardiology, they are taking a more precautious stance. So their stance is intermediate. They say that we neither oppose nor recommend the use of vitamin K antagonists in patients with AF. Why? Because we acknowledge that there is a large gap as far as data is concerned, and that gap needs to be filled. So there is a paucity of data, and therefore there is an absence of strong evidence in this regard. The question arises then, why not use antiplatelet agents like aspirin or clopidogrel or other antiplatelet agents? And the available data shows us that oral anticoagulants lower the risk of stroke and systemic embolism by 2/3 when you compare to other agents like antiplatelet agents in patients with AF. And therefore, there is no evidence that antiplatelet agents will be helpful in reducing stroke. They may be helpful, but the evidence is not very statistically significant. Oral anticoagulants are by far more beneficial when it comes to prevention of stroke. As far as scoring systems are concerned, just a reminder to all of you, particularly to students who may be attending this session, we use the Charts-VASc score, which actually stands in patients with renal disease. Even if you have renal disease, you can still continue using the Charts-VASc score. And we have the Hasblad score, which tells us or which helps us score patients' risk of major bleeding. And if you look at renal dysfunction or CKD, that is actually an independent predictor of increased risk of bleeding. Now coming to NOACs. These are the novel oral anticoagulant agents or non-vitamin K dependent anticoagulants. And we have 4 types or 4 drugs within this category. We have, and these 4 drugs are divided into 2 subgroups. The first subgroup is those drugs that inhibit the activation of factor 10A. These are apixaban, rivaroxaban, and edoxaban. And then we have one drug which acts as a direct thrombin inhibitor, which is called dabigatran. And this is the pathway, the intrinsic and the extrinsic pathway for the process of coagulation. Vitamin K antagonists inhibit the activation of factor 2, 7, 9, and 10. And the novel anticoagulant agents inhibit the activation of factor 10A, or they are direct thrombin inhibitors, as you can see in the diagram. What is the important take-home message in this slide is the renal elimination. So if you look at dabigatran, 80% of this drug is eliminated via the kidneys, which basically tells us that in advanced kidney disease, there will be significant accumulation of this drug. Edoxaban is the number 2 drug because half of it is eliminated by the kidney and the other half is eliminated by other mechanisms. And apixaban and rivaroxaban have lower renal elimination. This slide tells you or shows you results from the phase 3 trials for these different drugs. Now, what I want you to see here is the renal clearance, yes, but we've already discussed that. I want you to see the dose adjustments, okay? But more importantly, I want you to identify the fact that the exclusion criteria for phase 3 trials included patients who had a creatinine clearance of less than 25 or less than 30. So in essence, patients with advanced kidney disease were excluded from these trials. And therefore, we have no data from the phase 3 trials in regards to safety of using these drugs in patients with advanced kidney disease. When it comes to clinical experience, we have relatively less clinical experience using NOACs in the dialysis population when compared to warfarin. Number 2, which is very important, is that reversal of anticoagulation is very difficult in these patients. And even in the UK, it comes at a cost implication to the NHS. The patient doesn't have to pay for it, yes, but the NHS incurs a cost because these reversing agents are quite expensive. I'm not sure whether these reversing agents are available in sub-Saharan Africa, but I'm sure that the cost would be tremendous. Whereas reversing heparin or warfarin is relatively cheaper, and vitamin K or FFP is relatively easier as far as availability is concerned. Coming to the point, you must be thinking, this guy's beating around the bush. The question is, can NOACs be used in the dialysis population? So far, there is a large consensus group that says no. Why are NOACs not used? Because we all know that NOACs tend to accumulate in patients with end-stage renal disease, number one. And number two, there is a lack of data from clinical trials. Plus, in addition to this, the dialysis patients are already at a high risk of bleeding because of multiple factors, because of factors related to uremia, because of factors related to the dialysis session itself, and due to repeated cannulation of the vascular access site. This is the consensus. When you look at the actual situation on the ground, as far as use of NOACs is concerned, then the situation is different. As of 2015, in the United States, up to a quarter of CKD patients and up to 12% of dialysis patients on anticoagulation were given a NOAC in the US. When you look at advanced kidney disease, and by advanced kidney disease, I mean stage 4, CKD stage 4, stage 5, end stage, NOACs were prescribed as follows. So 10% of patients either received apixaban or rivaroxaban, and less than 5% received dabigatran. Apixaban was one of the leading drugs that was prescribed in the dialysis population in the US as of 2015. So these drugs were actually used in the United States. And this paper actually published a graph. The first graph shows the use of NOACs in patients with advanced CKD, and you can see that the use of apixaban started picking up in 2013. And the second graph shows the use of apixaban in the dialysis population, and about 141,000 patients were studied. And you can see how that the use of apixaban was actually increasing in these patients. Do we have any data on the use of apixaban in the dialysis patients? That what we saw earlier was the situation on the ground. What about data? So when we look at pharmacokinetic data, this study, which was published in the Journal of Clinical Pharmacology, studied two groups of patients. The first group of patients was given apixaban 2 hours before dialysis, and the second group of patients was given apixaban immediately after dialysis. And as you can see from these two graphs, when it comes to apixaban concentration in the blood, you can see that there's not much difference whether you give apixaban before or after dialysis. And this is data that looks at mean INR and APTT. The difference is not statistically significant. And therefore, this study gives us some important take-home messages. Firstly, 30 to 40% of end-stage patients who were given apixaban had 30 to 40% more exposure to the drug compared to the healthy subjects, which basically tells you that the drug is accumulating. Roughly 0.3 milligrams of apixaban was removed through dialysis, and therefore this is a very teeny-weeny amount. It's negligible, which basically tells us that timing of the dose in regards to dialysis is not important. Protein binding of the drug is similar between dialysis patients and healthy subjects, and there were no serious adverse events, including bleeding episodes. And therefore, this study concluded that apixaban can safely be used in dialysis patients without any dose adjustments, unless, of course, you want to adjust the dose according to the weight and the age of the patient. However, there was one problem. In this study, they only used one dose of apixaban. And in clinical practice, we use apixaban for long-term use, isn't it? We don't give a single dose. So this study does not really reflect the practice in renal medicine of giving anticoagulation to our dialysis population. What about use of other NOACs in the dialysis patients? So when you look at data, especially this study that was published in Circulation in 2015, that tells us that the other groups of drugs, dabigatran and rivaroxaban, are increasingly being used in the dialysis patients in the US, despite there being a paucity of data in this scenario. And the dose of these drugs is not appropriately reduced to account for renal impairment in this group of patients. So not only the use of apixaban is increasing, looking at the previous study, but use of dabigatran and rivaroxaban is also going up, despite the fact that phase 3 trials have shown that dabigatran is 80% cleared by the kidneys. So the situation on the ground is different. In the UK, NOACs are not licensed for use in the dialysis patients. However, it is ultimately the responsibility of the renal consultant looking after the patient to make that decision. So the responsibility is bounced back to the doctor on the basis of expert opinion. Do we have other evidence in this regard? The answer is yes. So this study looked at the use of rivaroxaban versus warfarin in patients with worsening renal function compared to patients with stable renal function. And as you can see from this graph, there is a significant reduction of the incidence of stroke and systemic embolism in the rivaroxaban group compared to warfarin group in patients with worsening renal function. In those with stable renal function, both the agents were similar when it comes to reduction of stroke. When you look at bleeding, incidence of serious bleeding, then these incidences are similar between rivaroxaban group and the warfarin group. So stroke and systemic embolism was less with rivaroxaban compared to warfarin, especially in patients with worsening renal function, and there's no difference in major or clinically relevant bleeding as an adverse event. Why? Is this because of the pharmacokinetics of this drug? So another study was done to answer this question. This was the dose finding study of rivaroxaban in the hemodialysis population. This study looked at 18 dialysis patients who had no residual renal function. And these 18 patients were randomized from 2 different hemodialysis centers in Europe. These patients were given 10 milligrams of rivaroxaban after 3 consecutive dialysis sessions, and the anticoagulant effect of rivaroxaban plus the area under the curve was measured for 44 hours. The conclusion of this study: 10 milligrams of rivaroxaban in hemodialysis patients with no residual renal function had the same anticoagulant effect as 20 milligrams of rivaroxaban in healthy subjects. And rivaroxaban, looking at the area under the curve, it was concluded that rivaroxaban is not eliminated by dialysis. But we knew this already. So we need to get more data. We need new information. So let's look at data from 2020. This study that was published in C.JSON in August last year looked at apixaban versus no anticoagulation in patients undergoing long-term dialysis. So they took more than 400,000 patients, and these patients went through a strong vetting process and exclusion process. They excluded patients with valvular AF. They restricted patients without any anticoagulant prescription prior to the AF diagnosis. They went on to vet the patients until they reached a final cohort where they had 10,900 patients who were not on any treatment and about 500 patients who were on apixaban. And then they used 3-to-1 matching for getting a propensity score. And they compared 1,500 patients who were not on any treatment with 520 patients who were on apixaban. The primary outcome for this study was significant systemic embolization, or TIA, or stroke. And the secondary outcome was fatal or intracranial hemorrhage. And these were the clinical outcomes. So incidence of stroke, TIA, or embolism, when they compared to patients on apixaban compared to patients who are not on any anticoagulation, then the apixaban group had lesser incidence, but this was not statistically significant if you look at the p-value. So there was a trend towards less incidence in the apixaban group, but you cannot make a conclusion because these figures were not statistically significant. However, when you look at major bleeding, then this is obvious because one group is not on any anticoagulation and the other group is on apixaban. So the group on apixaban had major bleeding episodes, which was statistically significant. However, looking at the group which was on apixaban, those that were on reduced dose of apixaban, 2.5 milligrams twice a day, had a statistically less significant incidence of fatal or intracranial hemorrhage compared to those who are on a standard dose of 5 milligrams. Okay? And therefore, this study concluded, looking at the primary outcome, that apixaban was not associated with a lower incidence of stroke, TIA, or systemic embolism. However, this study, those who were on a higher dose of or a standard dose of apixaban were at a higher risk of fatal or intracranial hemorrhage. And this was higher compared to the the patients who were on a reduced regimen. But this study had some weaknesses. First and foremost, this was an observational retrospective study. Secondly, this study did not compare NOACs to vitamin K antagonists. Number three, the propensity scoring, the 1 to 3 propensity scoring, did not capture all the differences. So there was a risk that there were confounding factors and a possibility of selection bias. And other parameters were not taken into account, like BMI, use of aspirin, use of other anticoagulants during dialysis, like heparin, for example, the actual dialysis prescription, and the absence or presence of residual renal function. So this brings us to the Valkyrie study. And this was published in the early part of last year. This was a study that looked at 132 hemodialysis patients with non-valvular atrial fibrillation. And these were patients, they compared patients who were on warfarin, who had a therapeutic INR, compared to those who were given rivaroxaban. And the third group of patients that was studied was those who were on rivaroxaban and also received vitamin K supplementation. And these patients were followed up for 18 months. The primary endpoint, however, was to study changes within the vascular calcification score during follow-up. But our interest mainly is in the secondary endpoints. And these included changes in the aortic and mitral valve calcification, not our interest. Mortality from any cause, yes, we are interested in that. The presence of ACS, symptom-driven revascularization, hospitalization for heart failure and death from any cardiac cause, and more importantly, we are interested in the incidence of stroke. And then they defined what they meant by stroke. So this is the data as far as the calcification score is concerned. And I will not go into that because that is not our main interest. But this table is what we are looking at. If we look at the third line where it says stroke or systemic embolization, if you look at the vitamin K group, it had a higher number. The rivaroxaban group had a lower number, and the rivaroxaban with vitamin K group had an even lower number of patients with stroke. However, once again, these differences were not statistically significant. You guys must be wanting to bash me up because we're back to square one. When it comes to life-threatening hemorrhage, again, patients with who are on vitamin K antagonists had a higher number compared to those in the rivaroxaban group. But again, this was not statistically significant. So what is the conclusion of the Valkyrie study? They concluded that withdrawal of vitamin K antagonists and vitamin K supplementation helps improve vitamin K status, yes. It has no favorable effect on vascular calcification. However, severe bleeding complication is lower with rivaroxaban than with vitamin K, which was one of our major concerns when we initially talked about the use of warfarin in our dialysis patients, severe bleeding. So this study shows that severe bleeding is lower with NOACs compared to vitamin K antagonists. The strengths for the Valkyrie study. So this was a multi-center randomized control trial, which is what we are looking for. These patients were real-life cohort patients. So they looked at patients from 3 different European dialysis centers. And warfarin was directly compared to rivaroxaban, thank God. Lakini, there's a problem. This study has got weaknesses as well. And the first and foremost weakness is the low sample size. And probably that's why our sample size was so low that our data could not get the required statistical significance that we wanted. So that's one. 2, there was a variability in the baseline calcification scores. And it was highly probable that those dialysis patients who were on dialysis for a long period of time already had a great cardiovascular disease burden, which is known. And therefore their calcification, their vascular calcification had progressed to a point which was beyond no return. So what have we discussed so far? We understand that as renal dysfunction worsens, the prevalence of AF increases. We have seen that. We have data that proves that. Secondly, the incidence of stroke and systemic embolism also is seen to be increasing in patients with worsening renal dysfunction, especially in advanced CKD. And therefore, these patients are at a higher risk of hemorrhage, particularly if they're taking oral anticoagulation. Up until eGFR of 30, we do know that oral anticoagulants reduce the risk of stroke and systemic embolization, and we have proof from RCTs. We also have evidence from RCTs that NOACs are not inferior to vitamin K antagonists, and in some instances they are actually superior when you compare adverse events up until eGFR of 30. But when you look at patients who have eGFR below 30, particularly our dialysis population, we do not have robust data on the evidence of use of anticoagulation, whether or not it's beneficial in the reduction of the risk of stroke and systemic embolization. We don't know that anticoagulation is beneficial, number one. Number two, when it comes to the use of NOACs, we still do not have any data from RCTs, which is statistically significant, that proves the benefit of NOACs versus vitamin K antagonists. I would like to conclude in this way. Use of warfarin in dialysis patients is common practice. Yes, we have to agree that the use of NOACs in our dialysis patients is increasing. And this is based on expert opinion and on the fact that rivaroxaban and apixaban is not associated with evidence of worsening bleeding or significant bleeding. But the benefit of using NOACs, the evidence for this is lacking. If we do decide to use NOACs, then it is important that we dose this appropriately. And we also consider reducing the dose of low molecular weight heparin during dialysis by at least 50%. And definitely more RCTs are needed in this regard. But before I finish my presentation, if you turn around and ask me, what have you done? I will tell you that yes, I have given some of my patients NOACs after discussing this with my colleagues. And we have been monitoring these patients closely. And touch wood, so far, we have not had any evidence of stroke, systemic embolism, or major hemorrhage in this very small group of patients, which are in single digits in our dialysis center. Thank you very much.
Wow. Thank you very much, Dr. Mubarak. That was excellent presentation. Very good presentation. So it's a time for questions and answers. Maybe you asked the experience that we have here, especially in East Africa and some other part of Africa. In East Africa, specifically in Tanzania, we use rivaroxaban, and I personally have used rivaroxaban at a reduced dose, 10 milligrams per day. And that patient didn't develop any risk, any stroke or any breathing disorders, complications, sorry. Therefore, and it is quite expensive, but thankfully it is now covered by the National Health Insurance Fund under special, permission and request from the NHIF. So the drugs are available and it works really well. But we need numbers. You can't rely on only one patient or two. But I would like to hear from others regarding this. Yeah, so time for question. Any other comment or question? So, Dr. Mubarak, if you are required to advise the use of NOAC or vitamin K inhibitors, which one would you recommend? Warfarin? If you have all the resources available, you can check INR whenever you want, anytime. Which one would you recommend then after this presentation?
Hello, Egna.
Yes.
This is Alfred.
Yes, Alfred, please.
My greetings to my colleague, Dr. Mubarak, my fellow Reno team member then in Bugando. Of course, the side effects of rivaroxaban and the other NOACs are much lower as compared to the vitamin K antagonists. But the major issue that I think its uptake might be quite challenging is the issue of cost. Despite the fact that the national insurance is covering it, but if we're having many patients into preferably using rivaroxaban, I think even that bag of the national insurance we might end up drying up because of the costs that are quite expensive. So the one concern was, my major issue is, if I'm comfortable to use rivaroxaban in my patients, why should I worry? Because I know it's much better than the other vitamin K antagonists. What should I get worried about? What should make me worry? Because as far as I'm from the presentation, from the literature that I was presenting, shows that the NOACs are much better. Thank you.
Thanks, Meremo. It's fantastic to hear your voice after a very long time, Meremo. The last time I heard your voice was in 2012.
Thank you very much, my colleague.
Yes, yes. So it's a very valid question. And Makwabe also asked a very valid, asked for my opinion as far as use of rivaroxaban versus warfarin is concerned. So to answer Makwabe's question first, in the UK, INR is very readily available. Okay, we can decide to do INR tests 3 times a week for our dialysis patients, and the patient does not have to pay anything. But despite that, we all agree. I mean, I'm sure all of us have a certain group of patients who always have poorly controlled INR, and we've all seen patients who come in with evidence of bleeding, significant bleeding. Within this category, with those with poorly controlled INR. Now, in our dialysis patients, especially those who have a fistula, you don't want your INR to be poorly controlled. At the same time, you have availability of rivaroxaban. In Tanzania, the situation is that it is expensive. I don't know the cost, how many shillings it costs, but I do know that it is definitely more expensive than warfarin. At the same time, when you order INR tests, the patient has to pay for it as well, or NHIF has to pay for it. So there is a cost when it comes to INR. There is a cost when it comes to patient having labile INRs, and therefore requiring frequent medical reviews because of their poorly controlled INRs, and the cost of the warfarin. So there's an added cost in this group of patients. My advice would be, if you have a patient who is on warfarin, number 1, number 2, is benefiting from warfarin, and number 3, the INR is more or less therapeutic and stable, and it's not challenging to control the INR, then yes, continue the patient on warfarin. But you have a group of patients, or a patient who has got very poor INR control, is elderly, and is finding it difficult to take warfarin as per medical advice, and therefore it will be more beneficial to take a medication where you just pop a pill and you don't have to do any monitoring. Then in that case, it is advisable to prescribe rivaroxaban based on your expert opinion. So you'll ask yourself, what am I achieving here? And what are the risks? If the risk of bleeding is high, the patient is not adhering to your prescription, and the INRs are labile, then obviously rivaroxaban is more beneficial in that scenario. That would be my advice to you, Makwabe. Now, Meremo raised a very important point about cost. And I think I partially answered that the cost of, you have to take into consideration, so you consider the cost of warfarin itself, you consider the cost of INR, the cost of hospital admission because of bleeding, and the cost of medical review. Having said that, you have to then sit down and compare that to the cost of rivaroxaban, and then make an assessment on your own. At the same time, yes, the data has shown that adverse events with rivaroxaban are not significantly higher when you compare it to vitamin K antagonists. But remember, this data, all the studies have shown, have a lot of significant weaknesses, especially the RCTs. And the Valkyrie study, which was a landmark trial when it comes to rivaroxaban versus vitamin K antagonist, had a very small sample size. So I would advise that you decide what you want to do individually, the way we're doing it and the way our colleagues in the US are doing. But for those of us who are involved in academics, people like Meremo, I would encourage you people to actually do a study, try and do a study. You have the numbers, you have rivaroxaban, you have warfarin, you have all the necessary tools. Why don't you do a study, especially in sub-Saharan Africa, which would give you a very detailed picture of the situation on the ground.
Oh, thank you.
Thank you. Thank you very much. Dr. Bima Rehandra. Dr. Bima, you have raised your hand.
Yeah, yes, Jana. Thank you very much. Dr. Mubarak, firstly, I have 2 disclosures. One is I'm from pediatrics, so I don't want to put you on the spot for anything pediatrics. My second disclosure is I have no experience with the use of these drugs, okay? But my question is, obviously, it seems to be very useful in patients, and I hope this randomized controlled trial takes place in sub-Saharan Africa. Just one thing, how long would you say you need to stop this before patient has undergo surgery or anything? What's the half-life?
Sorry, I was muted.
Sorry, I can't hear.
So for warfarin, Rajendra, you have two options. You either, if the surgery is not required immediately, you stop the warfarin. Obviously, you always have to discuss the benefit and risk of stopping anticoagulation with your patients, especially in regards to the surgery. You tell now if your patient has got, for example, the patient has a metallic heart valve and is on warfarin because of that. The risk of stopping warfarin is very high. So you have to discuss benefit and risk of stopping anticoagulation in this group of patients. That's the first step. Then you have two options. If the surgery is not required urgently, you can wait for your INR to become therapeutic, or better still, you stop the warfarin, reverse it with FFP, send your patient for surgery, and then after surgery, depending on what procedure they had and the advice from the surgeon, you can restart anticoagulation. So that's for warfarin. When it comes to NOAC, the half-life in healthy subjects is 24 hours. We do not yet know for sure the half-life in dialysis patients, but we do know from our data that I have shown from studying the pharmacokinetics that these drugs have been found in significant amounts within the body up to 48 hours after administration. What we do in our setting, when we send these patients for any procedure, if they need a minor procedure or a major procedure, is we talk to our hematology colleagues and we seek advice. Does the patient need factor 10A to reverse our NOACs, anticoagulant effect of NOAC, or should we just stop NOAC and wait for 48 hours and then advise them to go for surgery? What we do, however, is that we check factor 10A levels in these patients just to be on the safe side. So you can check factor 10A levels. But in healthy subjects, the half-life is 24 hours. I hope that answers your question.
Thanks. Thank you. No, that's a big help. So to check the factor 10, wait 24 hours, and then discuss with the hematologist. Right?
That's the best.
So
That's the best option.
Yeah. Okay. Now, thanks. Much appreciated.
Yeah, Dr. Mubarak, thank you. Very good answers. What about the dabigatran factor 2 inhibitors? Your experience on that? Do you use it in the UK? It's also widely available here in Tanzania. Cardiologists use it more frequently, but haven't seen it being used by the nephrologists. Yeah.
So in the UK, dabigatran is readily available, but we don't. The nephrology world does not use it very often, I'm afraid, and especially in dialysis patients, we avoid. I haven't heard of anybody using dabigatran.
All right, thank you. I think the same as here in Tanzania. So can you read the chat box, or I should read it for you? You unmute.
I got carried away. I did not see the chat box, and there are a lot of messages here.
Yes.
So I'll start from somebody called Privilege Makanda. Thank you for your talk. Can it be used in children with CKD? So I'm afraid I don't know. I have no experience with pediatric nephrology. In the UK, pediatric nephrology is taken care of by pediatric nephrologists only. So probably I will ask Rajendra to reply to this question.
I'm afraid I don't have experience with the use of NOVAX in pediatrics because we don't use it. You know, in fact, we don't, except for the use of heparin during dialysis, we don't routinely have to anticoagulate. Atrial fibrillation and other quite low in the pediatric population. Very, very rarely will you get patients using a metallic valve, because nowadays with the new prosthetic valves, you know, the cardiologists don't use high doses of warfarin either. So I must say our experience in pediatrics for that is very limited, but I am open to suggestions from any other pediatric nephrologist. I haven't got any experience with it.
Thank you, Rajendra. Is there any other pediatric nephrologist? Is Frederick here? Frederick Francis.
Yes.
He is not.
He's
haven't
not
seen
here.
him. Yeah.
He's run away today. We need to penalize Fred. Okay. So I'll move on to the next comment. It's from Dr. Amir Ali. He says majority of these studies have been performed in patients with AF. What about patients with DVT and PE? Which is a very valid question. I have not seen studies performed in this group of patients. And he rightly says that he's asking this question because different use, the dose for anticoagulation in these conditions is different. But he also says that there is a lack of a reversal agent. I think this would be in the case of Tanzania, maybe. Reversal agents may be difficult to find. At the end of the day, it all depends on the risk benefit of these drugs and individualization of patients. Exactly, that's what I was pointing towards. It all depends on individualization of the patient and on the nephrologist who is looking after that patient. So we definitely need more studies in that field. And then we have somebody else who says, very interesting talk. I used rivaroxaban in 2 patients who always didn't finish dialysis because of blood clotting, despite being given large doses of heparin. It works. So that's good to know. So that's a good experience regarding rivaroxaban use in patients who clotted their circuits. That's fine. That's okay. That's good. You can actually do some write-up or publish a case series. If you can, that can be documented actually. And then we have Steve who says, thanks, this is an excellent talk based on current realities amongst our dialysis patients. We have patients on various anticoagulants, including some on rivaroxaban, and we have observed bleeding amongst some of them as a complication. Okay, so that's experience from Steve. So bleeding will occur, yes. It was just that it was less significant compared to warfarin based on the data that I presented. Lloyd is asking, how common is anticoagulation nephropathy and AKI in non-dialysis CKD patients on anticoagulation? I see it in literature, but I have not had any personal experience. I also have not had any personal experience. We have not come across any patients in our trust and in the previous hospitals that I've worked in the UK who have presented with anticoagulation nephropathy. I don't know about other people. Has anybody come across such patients? Nobody? Okay.
Yeah, seems not.
Nobody. Okay. And then we have Dr. Mgumi, who is, I think he's asking a question. Nice presentation in reference to these studies, weaknesses. Suppose the study includes more numbers. Would it bring any changes to the findings? So it is known in research methodology that if you include a large cohort of patients, then for you, you get a higher chance of getting findings which are statistically significant. So whatever sample size you calculate, that's a minimal sample size. So correct me if I'm wrong, it is always encouraged to include a higher sample size because that then gives you a higher chance of getting findings which are statistically significant. And then we have Dr. Mukaya, who says very interesting talk. Oh, okay. I think that has already, I've already mentioned that. Samuel says, thank you very much for the presentation. What is the experience with anticoagulation in patients with arteriovenous fistula as vascular access? So we do not have any, I'm not aware of any strong evidence on the use of oral anticoagulants to prevent recurrent thrombosis in vascular accesses in patients who have such problems. What I have seen in the UK is vascular surgeons asking certain groups of patients to be put on oral anticoagulants, particularly warfarin, especially patients who have poor vascular access or a poor vascular access history, and patients who have, they're running out of access and they have recurrent thrombosis. So I have not come across any such study. Maybe other colleagues can contribute. I think Mazhar is raising his hand.
Yes, Mwanza, please.
I'm actually raising my hand to ask a question. Sorry, guys.
Go on, Mwanza, ask a question.
Yeah, so hi guys, everybody. Thank you, Mubarak, for this lovely presentation. So just to kind of clarify the matter, in the conclusion, you mentioned that the dose should be adjusted based on the renal function if you were to use this, and probably reduce the heparin dose by 50%. Now, as far as I know, I mean, the dose recommendations for all of these drugs are above a GFR of 15. So what do we do if a patient, say, for example, has a line catheter, temporary line, has a DVT, or has AF? How do you adjust the dose? Say, for example, for AF, you have to use rivaroxaban at, say, 15 milligrams daily. That is with normal renal function. Or with a DVT, you have to use 15 milligrams twice a day for 3 weeks, then 15 milligrams daily for, another, 6 weeks or 8 weeks. How do you adjust that to patients now on dialysis? Do you reduce the dose? Do you keep the same dose but half the heparin? Like, do you have any guideline for that? Because I can't seem to find anything.
So if you look at my my data that I have presented, apixaban, one of the studies which looked at the use of apixaban versus no anticoagulation, they noted that those patients who used the standard dose of apixaban, 5 milligrams BD, had a higher rate of significant bleeding compared to those who used reduced dose of apixaban. And therefore, if you are using reduced dose of apixaban, you need to use 2.5 milligrams BD. That's what I have used in my dialysis patients. When it comes to rivaroxaban, they concluded that 10 milligrams of rivaroxaban in a dialysis patient has the same anticoagulant effect compared to 20 milligrams of rivaroxaban in healthy subjects. So in the dialysis population, you need to halve the dose by to 10 milligrams. So that's the recommended dose that they have suggested in that study. The other, during my conclusion, as far as intradialytic heparin use was concerned, I gave a reference, and that study advises that reduce your dose of intradialytic heparin by 50% if your patient is on a NOAC, because so as to reduce your events of significant bleeding even further. So yes, your patients on dialysis need to have reduced dose, and these are the recommended doses for AF. Now, if you have these patients with lines and you are potentially looking at a line exchange or a line removal, then you need to stop the anticoagulants before your procedure. What we do in our setting is most of our patients are on warfarin. Very few are on NOACs, if any. At any time, maybe 1 or 2 patients are on a NOAC. So what we do for those who are on warfarin is we stop the warfarin, we give vitamin K, we measure the INR, make sure it is at least less than 1.6, and that is our local. Somebody muted me. So that is the local policy within our own trust. To have, if INR is less than 1.6, then I'm personally happy to remove a line or to do a line exchange. Some nephrologists don't want to do a line unless the INR is less than 1.2, which is fine. I personally am happy to take the risk. I've done lines in patients with an INR of 1.5, 1.6, a tunnel line, perm cath insertion, which is okay. I've not had any experience with bleeding. So that's what we do with patients with warfarin. Patients who are on NOACs, we stop the NOAC for 24 to 48 hours. And just to be on the safe side, I ring a hematology consultant and tell them that this is my plan. I've stopped it for 24 to 48 hours and I plan to do a line insertion or a line exchange or a line removal. And if the hematologist says, yes, go ahead, then I document it to protect myself medico-legally, and I move forward. And so far, touch wood, no problem.
Thank you.
All right. Thank you. Thank you very much, Mubarak, for very good answers. We still have a few minutes, 1 or 2 or 3. If there's any questions or comment, please, you're welcome.
Ben Clement asks a question. What is the target INR in dialysis population? It's the same target INR. It is 2 to 3. And in patients with metallic valve, it is higher. But in non-valvular AF, it is 2 to 3. And the other question is, some patients go up to 10 milligrams of warfarin without reaching the target INR. What is your take on that, especially if finance is not allowed, NOAC? That's fine. We don't look at the dose of warfarin. We make sure that the INR is therapeutic. Some of my patients are on 1 milligram of warfarin. Some are on 10 milligrams of warfarin. It's all individual. Pharmacokinetics change, pharmacodynamics change. So it's all based on the individual patient characteristics. Just make sure that your INR test result is reliable. That's most important. And if it is reliable, then just go up on the dose of your warfarin. The important thing is your INR should be within the therapeutic range.
All right.
That's about it.
Yeah. Yeah. If there's no any other questions or more questions or comments, I think I should take this opportunity to thank you, Dr. Mubarak, for taking time to prepare and present to us, for sharing your knowledge to your colleagues in Tanzania and the rest of Africa and the world. We really appreciate your time. And I should thank all of you who participated in one way or another. I should thank Dr. Lloyd, who has been working tirelessly behind the scene. And so we have come to an end of our presentation. Dr. Mubarak, I think we'll ask you again to come again for presentation. It was excellent talk.
It's my pleasure, anytime.
All right, thank you. So I'll see you next week on Thursday. Thank you very much for your time, and thank you for joining.